Now it's time for all things mental health with your host, Dr. Nicholas Goodwin. Come on in, take a seat. All are welcome here. It's Health Cafe Radio.
It's been a while, so how the hell have you been?
All right, welcome to Health Cafe Radio, KSPN 1230 AM. Happy 6:05 p.m. This is Nicholas Goodwin, checking in here, hanging out with Aaron Tilbury.
Hello.
He's professionally producing, no club mixes, anything like that. We got a kind of a new intro, which I really dig. Old Bear Mountain is the artist who wrote that song, and they are friends of mine, so I was able to reach out to them and ask them if it's cool. I used their music, and they said it was. They're high school friends, and one of them is a urology resident, and the other one I think is a neurology resident. Like, they're physicians now. It's crazy to think that somebody you went to high school with is now like a physician. And
just think what they think of you. They're like, wow,
yeah.
Our little Nick made it big.
Yeah, little Nicky. Remember you, buddy? And those overalls you used to wear? We all that. No, didn't wear a lot of overalls. A lot of fanny packs, maybe. This is going to be part two of talking about suicide. The topic of suicide. In this session, I really want to talk about specifically, how do you interact with somebody, or what do you do when somebody that you love either tells you that they're thinking about suicide, or or you think that they are at risk for suicide? And we'll sort of talk about how to sort of, be concerned and different approaches to take with people that you love. And I probably will mostly frame my examples for, like, parents working with their children who are suicidal. I think that most of my interventions can be used for other people, but just because of the clientele that I work with, a lot of kiddos, it'll probably just inherently be, I'll naturally sort of refer to if your kid is doing this, etc. But I think a lot of these approaches can be used for anybody. But before we do that, I do kind of want to do a little bit of review and maybe just spend a little bit more time talking about specific risk factors for suicide, and some of the I think these risk factors, and also maybe some of the myths that we talk about, are surprising. I'm often surprised by them. When I teach this content to my nursing students, a lot of them are surprised by it, and a lot of times they feel like it conflicts with their own personal experience. And I think a big distinction that I want to make is that I'm going to talk a lot about suicides where the person who attempted suicide died by that suicide. Whereas I think that these statistics may not necessarily apply to people who've attempted suicide. And to give you an example, most people who commit suicide are sober, are completely sober. And that really surprises people that is statistically true. Matter of fact, the less sober somebody is, the lower rates of suicide there are. I think that attempts, maybe people attempt a lot when they're not sober, and also the difference is that people who have substance use disorders or chronic substance abuse, that is consistent with somebody who's suicidal. People who are suicidal tend to have these drug use disorders, but what will happen a lot of times is that they will become sober and then kill themselves. And sometimes they will be sober for 3 days. So they'll have alcohol use times decades and then become sober times 3 days, which I imagine can be very confusing for the family, who probably saw that 3 days of sobriety as improvement, not as a concern, right? And so that was probably very unsettling. I imagine horrific for them, but that can happen. So and I think that comes to this idea that most of the time we think of suicide as this impulsive, last-minute thing that somebody does, where they don't have a lot of thought about it and they just sort of do it eventually. And I think what happens, where this comes from, is probably comes from the biggest part is that a lot of times people won't talk about their suicidality, and so instead of it being impulsive, a better term, which is used by Thomas Joyner, who I'm using most of his material here, is it's not impulsive, it's out of the blue, and that it was unanticipated by family, though the person themselves were was a decision. Like it was.
So it's just kind of flipping it impulsive. It's kind of flipping the lens of perspective out
Yeah.
of the blue from our perspective, but not impulsive. Yeah. Makes sense.
Exactly. And so, but like I said, 70% of people who died by suicide talked about it, right? So you're looking at 30% is a lot of people, but most of the time they do talk about it. It's probably your biggest risk factor. But there's still a group of people that won't talk about it, and so that's when it's surprising, where the people feel like, he was the last person I would have expected to do that, etc. That it makes me think of, I don't know if you heard about this. It makes me think of the youth. I think it was a youth pastor of a big church that ended up committing suicide, and he talked about suicide a lot. And did you hear about that? I'm not sure if you heard about that.
So actually, and I don't know if this is the one you're talking about. It could be. It wouldn't surprise me if it's a different guy or the same. But there was a guy who actually he was a pastor, but he made a living. He was actually a neuroscientist.
Okay.
Made a living speaking about how we deal with grief.
Oh, okay.
And he specifically he lost his child in Sandy Hook.
Oh,
and it's
wow.
one of the reasons that he was a speaker.
Yeah. He was able to
kind of made some of his bones, I think, counseling some of those parents through grief.
Right.
My wife, as you know, who deals with victims of trauma, pretty often, if not every day, like every other day or multiple times a week, went with a group of other women that does what she does with trafficking victims and heard this guy speak.
Yeah.
I think it was maybe 2 years ago. And then this last year, he took his own life.
Wow.
It was just incredibly profound for them, impactful for them, because one, they had heard him speak. He was a super cool, powerful, like kind guy.
Right.
With everybody's impression, but he was literally a professional grief counselor.
Yeah.
And took his own life.
Right.
Could not get over his daughter's death, apparently.
Yeah.
Even though so this stuff's complex.
It's complex, man. Yeah, it's totally complex. I think it's a different guy, but that's a great example. I think the person I'm thinking about, he really challenged the theology of everybody who kills himself going to hell. And so he pushed that.
I think that is a different guy, but I'm totally interested in hearing about this.
Well, he really challenged it. So, in a way, he died by suicide, but in a way, he also, I think, he really helped with a lot of the pain for suicide survivors who are religious, who would have been torn, right? What do I believe there? And so he likely, there's probably a lot of healing that people had from him because he really challenged that theological perspective. But then, then he went and he ended up killing himself, and his wife ended up writing about it, and it made you cry. I should find it next time. I'll have it ready and I'll read it because it's incredible. Her ability to be honest and raw with her emotions. Again, probably very healing for a lot of people, even though she's going through what I imagine is the worst thing you can go through. But it speaks a little bit to this theory the idea that people who kill themselves, who die by suicide, don't do it impulsively, that it's on their mind, right? That they think about it a lot. And I'll kind of speak to how we can use that information to help us decide how we interact when we know somebody is feeling suicidal. Because what I really notice is that when people express suicidality in an environment, it's usually done out of crisis, right? The expression of their suicidal thoughts is usually done in a crisis, not usually, but a lot of times it's done in crisis, or it's done to try to make a need being met, right? Like, my dad doesn't take this seriously unless I say I'm going to kill myself, right? So it's used as a tool. But a mistake we can make is think that's not legitimate suicide. Or even a mistake we can make is thinking that period of their time is when the suicidal thinking is worse. Well,
or you get responses. I've heard people have talked with me about stuff that they're going through, and I've heard things like the response was don't threaten.
Sure. Yeah.
Don't threaten me.
Yeah,
and it's perceived, and it, instead of helping this child, you become defensive, and you perceive that child is trying to leverage you somehow.
Definitely. And in a way, it kind of is, right? If you're in a crisis with a kiddo, and they say that, it is kind of a threat, and they are trying to leverage you, right?
Sure. There is some reality to that, too, yes.
And I would say the goal here is that because like I said, I don't think for a lot of people that's the peak of their suicidality is at that moment. I think it's elsewhere. I think they just don't feel empowered to talk about it in other times, and so it only comes out when they feel like there's nothing to lose, right? It only comes out as like, yeah, well, this is how I've been feeling. So the goal isn't necessarily, the goal is during a different time is to allow that person to express their suicidal thinking in a more safer, less stakes environment, right? Where they feel safe and empowered to express that. That's what your goal is.
Right, which, I guess if we're talking about kids, for example, which is, I'm usually mostly dealing with kids, but that's the idea, right, of walking that parent through actually, rather than going crazy right here, this is an opportunity for you to sit down and explore this with the kid.
Definitely.
Right?
Yeah. It's like, now that you said that, let's see what we can do about it. Yeah. So going back to some of the risk factors, and some of maybe we'll talk a little bit about myths because they can be very surprising. We talked about the first one. It's not an impulsive thing. People often will be suicidal or think about suicide for a long period of time. And for example, Kurt Cobain, the singer of Nirvana, right? He killed himself. He died by suicide. But when he was a kid, he was terrified of guns. He was absolutely terrified of guns, and he was also terrified of needles. And then when he became an adolescent, he would go on car rides with his friends, and on these car rides, he would sit in the car while his friends would go target shoot. He wouldn't even get out of the car, but he would still go with them. And eventually, he got out of the car, and he went, and he would start to participate. And then when he became an adult, he was a gun owner, and actually he used IVs, drugs, right? And so there's lifelong process where he sort of desensitized himself to these means, right? And then he ended his life, right? And that speaks to the other element of it being a long, insidious process, and at the same time becoming a process where it takes a long time to build the ability to take your own life, right? People can feel very suicidal, but not be capable of taking their life because there's like firewall systems in our psyche that prevent us from doing that. And that's what we talked about last week when we talk about people who will get on the other side of the bridge, which is terrifying, and then they'll allow themselves to be rescued. Or the woman who stood in front of the train, then last minute her body made her fall to the ground, and then she survived the train. So her suicidality was real, was intense, and she was able to kill herself to an extent, and then her body. So the body has a lot of ability to rescue. So that process that fearlessness that you have to get to in order to do it can take a long time. And so it's not an impulsive decision. It's something that a lot of times people will experience and have for a long time. And a big mistake people will make is saying, well, if they haven't done it yet, right? They've talked about suicide for years and years and years, and they haven't done anything about it yet.
I hear that. I've heard that a lot.
Yeah. You hear that a lot, and I don't think it comes from a place that I don't care for my loved one. I think it comes from a place that I'm emotionally exhausted from this process. I have complete, absolute, empathy fatigue, right? Where and so I'm doing whatever I can to rationalize the situation. But there's been situations where somebody's talked about suicide for decades, and then they end up dying by suicide because it took that long, and in that process. And so, and what that can look like sometimes, which is can be a risk factor, and I have some personal experience with this too, more professional experience with this, is the person has these thoughts for a long time, and they've dealt with them for a long time, and then when they've made the decision that they're going to die, when they made the decision they're going to take their own life, there's resolve there, right? And I don't know if you've ever, I'm sure you have, where maybe you have a really stressful decision you have to make, and you just chew on it for maybe a week or a weekend or a day, and then when you finally know what the right answer is, you just kind of feel at peace with it. Have you ever experienced that before?
Yeah, I've always explained it as it feels like I took off a backpack.
Yeah. You finally, I know what I need to do. And even if it's a hard thing to do, even if it's a difficult thing you've decided to do, the decisional process is over and you feel calm. And there can be this calming before a suicide, where the person isn't stressed anymore, and maybe they're sleeping.
They've resigned themselves to the action. Is that what we're talking?
Yeah, they've made the decision to do it, right? And so there can be sort of an improvement there, which I imagine stressed out family members would cling on to as improvement, right? Or like I said before, the drinking, right? If they stop drinking for several days and they've been a lifelong alcoholic, likely the family will hold on to that moment because they've been drowning in it, right? And they've clasped onto this finally a sign of improvement, right? After all these years, and then what it leads to is actually a resolve or decision. And so it's this decision to do it, is decision to do something incredibly difficult, right? To kill yourself is incredibly difficult. So what you'll see people prior to suicide is you'll see, and actually you can look at videos. There's a video of a guy who recorded himself. The video doesn't show him hurting himself or anybody, but he doesn't blink at all. So a blink rate is probably one blink per 3 to 4 seconds or something like that, or maybe every 10 seconds. But this idea, this hyper focus that you'll see maybe with boxers before they're going to go into a ring, or NASCAR drivers, or people who are going to jump out of an airplane, right? That hyper focus, there's a blink rate of maybe 1 to 2 per minute, right? And what that is that hyper focus that an athlete will get sometimes. And so I honestly have never assessed for that. I honestly don't think of it when I'm talking to somebody about suicide, but it's an interesting what it speaks to is an interesting process that somebody just doesn't impulsively commit suicide. That it takes a lot of effort there.
It seems to me that just when I say from experience, obviously it's not the type of experience that you're talking about. Just hearing things from family, things that you go through as a human being over life, and just different situations. And then obviously, the counseling that I've done. But that seems to be something that, I don't know, would seem to be fairly common, like that kind of period of resignation.
Yeah.
And I could absolutely see how, as someone who cares for that person or is around that person, why you would want to hold on to that is, okay, something happened and they've gotten to the other side of this.
Yeah. This is over. Yeah. Well, the experience that I had with it is not when I was a nurse practitioner or provider, but when I was working as an RN. I had there was a client that I did work with at a certain point. I wasn't working with him anymore, but the client took his own life, and I talked to another professional who worked with them, and they talked about how the night before he took his own life, he had a moment with a loved one, right? And I'm being very vague, but it had a loved one who he was able to reconcile with. Mm. And a lot of the other healthcare professionals that were working with this individual were very moved by that. Mm. That was because this person was very difficult to work with, right? It was not necessarily a pleasant person, a very withholding person. It was very frustrating sometimes to work with this person because chronically in the system. But there was this moment with resolve, and then the next day he took his own life. So it was definitely unsettling because I don't know if any of us really knew that. I don't think this is something that's been widely educated about. Mm-hmm. The next myth about suicide is suicide note myths. And let's see, most studies that look at people who have taken their own lives or died by suicide state that probably about the percentage of people who leave a note is between 7 and 40%, probably around 25%. So a quarter of people who take their own lives will leave some sort of note. Okay. What would you think? Why would you think that's it? Why so low?
Why so low?
Right.
I guess.
I think a lot of people think that most people write notes, but maybe that's not what people think.
Yeah. I guess. Well, and I don't want to sidetrack from what you were getting at here. I don't know that I necessarily would think that would be a low number.
Okay.
The reason is, I guess, is that it's tough to. From my frame of reference, I don't want to say experience, whatever. My frame of reference, I can imagine at that point people being so checked out in terms of feeling like no one gives a rip about them, or there's so many broken relationships. It's like, at this point, who am I going to write a note to? Everything that's been said has been said. Yeah. Although I guess if I would have probably guessed, I probably would have guessed at 50%. So you could argue. Yeah. That's low. Yeah. I don't know. That's just my perspective.
And I think you're right. I think that's, I think what I would say more specifically it is, and I would say is so you're looking at, this triad of high suicidal risk symptoms that have to exist in order for somebody to commit suicide, and one of them is the fearlessness or the physical capabilities of committing suicide. Another one is burdensomeness, that they feel like they're a burden to others. And so I think a big distinction here is that they don't write a note because they think that, there's no one to write a note with, like you said, because they're, in their perspective, they feel like everyone's going to be better off now that they're gone. Right? They believe that they have been such a burden that they have been such a burden on other people that everyone's life is going to be better once they kill themselves, right? And that can happen in a moment, like that can resolve. And I've seen clients who've been able to reflect and said, no, I had this time, this day that I really thought that, and then I was able to later on identify people that it would hurt. But sometimes in that final decision making, where they'll sort of believe that, right? And it can be perceived. And so the idea that they don't necessarily write a note is for the same, exactly what you said. They've it isn't because they don't want to say, I know I'm hurting you, but I want you to understand. They're not saying that. They're saying that that there's nothing to say, right? They're saying, like, right. you guys wanted this, right?
Right.
In some capacity.
Right.
And so we talked a little bit about that last week. And the other big risk factor here is the loneliness, or the thwarted belongingness is what the interpersonal theory of suicide identifies, and that's has been sort of at least it was been given to me by Thomas Joyner, not like personally, but Thomas Joyner's experience, his own research is why I'm familiar with those. And in my own experience working with, it seems like a lot of people who are suicidal that I really identify with this theory. So in order to be able to take your own life, you have the loneliness, the burdensomeness, and then you have the fearlessness. And I see a lot of people with the loneliness and the burdensomeness, that their fearlessness isn't necessarily there. So you have all the suicidal ideation, the suicidal thoughts, sometimes the suicidal behavior, but you don't necessarily have the suicide attempts or the completion rate, right? But a lot of times people are building to that. And it's interesting, that sort of inoculational process, interesting isn't the right word, I think it just inherently say that, but inoculation process that I talked about, like with Kurt Cobain, and specific diseases that tend to have a high risk of suicide. So people who have anorexia, 8 out of 10 of them who die from complications of the anorexia die by suicide, right? And not by necessarily complications of whatever the malnutrition is, okay? And you can kind of theorize that well maybe because of the malnutrition that exists in anorexia, that puts them particularly vulnerable to any suicide attempt. But when you look at the actual attempts, then you see that the attempts are actually are pretty they're pretty deadly, right? The means are pretty deadly. So that would only work if their means weren't necessarily deadly, but they were more susceptible to the attempt and die from it. So but I think the theory is that actually that people with anorexia have been practiced isn't the right word, but they've spent a lot of time doing things that your body isn't designed to do, and they've been pushing past those psychological firewalls, and they're able to, right? And that's just what we're talking about. They have the capability of doing it, so therefore when they have that perfect storm of suicidal symptoms, they're able to then they have that fearlessness, and then they also take their life. Another staggering statistic that I just heard the other day, sort of preparing for this topic, is I heard that people with bipolar disorder, 20% of them will die by suicide. And I don't know how that can be true. But I don't know. The podcast that I was listening to, the professionals were experts in it, but that's incredible. That's an enormous number. And think about all the people with bipolar disorder that I've treated. To think that 1 out of 5 will die, or statistically will die by suicide, absolutely blows me away.
Do you think that, and this is just me as a statistics and studies guy.
Yeah.
So this is not, I'm bringing nothing to the table here in terms of actual mental health experience in terms of this perspective.
Yeah.
I just see studies and data, and I wonder if how much of that is misdiagnosis.
Sure.
Or how much of that, you know what I mean?
Bipolar is so hard to diagnose.
Yeah, so I guess that's, having said all that, I mean, any number, is something that we want to address. I'm not trying to belittle anything.
Right. The fact that they maybe just had 100 people with bipolar disorder and found that many, still it blows my mind.
Sure.
Yeah.
Yes.
And I agree. There's no way to say exactly. And it would be a mistake to say, I have bipolar disorder, I'm 20% likely going to die by suicide. Right. That's not how a statistic works.
The reason I bring that up is because my mom, as we talked about this before, and so we were told by a doctor when we were real young that it's 50% likely that the child of a suicide victim will commit suicide.
Really?
And so my dad, literally, I remember having a conversation as like a 12-year-old, 13-year-old with my dad.
Right.
And him, like, you know, he was in a bad way. Probably should not have approached it this way.
Yeah.
But like my sister's 8, I'm 13, and he's like one of you's taking yourself out.
Wow.
Okay.
Yeah,
so
yeah.
I mean, I don't know if that's
Yeah.
a real statistic, but I remember being told that by.
Yeah.
So,
I don't. That's not a real statistic. That's incredible. Yeah. And to say that to somebody with bipolar disorder, I wouldn't. But I think that it's something to just be mindful of the risks that exist. That's all that I'm trying to say is that.
Yeah.
Is just looking at, because what you do is you say, oh, there's somebody that I'm working with, there's somebody that I know, that I love, or I personally have bipolar disorder, whatever the situation is, right? The mistake is to say that one of these things in isolation is really means a lot, right? Because anything is a risk factor, right? Anorexia, all these things are risk factors. But to look at something is you want to look at everything, right? Yeah. What exists in a total. So I'm really glad you brought that up because I really want to emphasize this. What exists, what is everything that we see here? And you have things like, so you're able to identify the loneliness and the thwarted belongingness, and you see, well, there's also mental health issues there with substance abuse. The person may be making statements like, I don't want to, you look at all of these things together, and you sort of start to connect the dots, right? As a clinician, I specifically look at that all together to sort of identify a risk here. But as a loved one, I start seeing these things because a lot of times it's hard to catch the suicide. It's hard to identify the suicidality. 30% of people won't say anything about it. And so
we probably don't want to believe either, right?
Yeah,
that
absolutely.
someone we love might.
Right.
I mean, that's probably hard to come to grips with.
I mean, it's incredibly hard to grip. I see people struggle with all the time because it's and suicide itself. It's so complicated, and we think, well, what did I do? Wrong with the parenting, or what are genetics we pass on? And really, they haven't been able to say this one thing causes suicidal thinking. So it really can't. There's genetics, there's chemistry. There's environmental insults.
I hadn't even thought about that, but I can totally see myself as a parent, immediately going to self-blame.
Exactly, and a lot of parents do go straight to self-blame, and so which we haven't seen. There's definitely a genetic component, and there's definitely an environmental component. But every individual person that I've worked with has their own series, and it's not always one thing. So when we come back, I will use I'll kind of talk about what I've been talking about in context of how do we. If someone comes to us and says that I'm feeling suicidal, or we think maybe they're suicidal, how do you deal with it? How do you work with that? What do you say to them? So we're going to go and lead into a break, and I'll see you guys in a couple minutes.
Hey Spokane, this is Nicole with A Time to Dance. Do you love dance? Or maybe you've dreamed about exploring the art of movement. Come visit us at A Time to Dance in the Garland District at the corner of Garland and Post. Explore the freedom that dance can bring. We offer high-end education, experienced instructors. Visit us on Facebook at A Time to Dance or call 509-995-5207. Now for details. That's 995-5207. Come join us on the dance floor.
Hi everyone, this is Dr. Steve Crosby here at Stephanos Ministries. If you stepped away from church or Christian life or faith in general, we at Stephanos Ministries have materials that could be helpful to you in navigating your questions about prayer, worship, church, scripture, but most importantly, your relationship with Jesus and with one another and the world. We have stevecrosby.org is the blog. Brothers in a Basement is our podcast with my friend Brian Wiebold, and stephencrosby.soarlms.com, stephencrosby.soarlms.com. stephencrosby.soarlms.com. Video and audio resources there for you, and some of them are free. So if you're facing challenges in Christian life, just like the rest of us, don't walk away from Jesus. Walk toward your Father. And thanks for listening.
All right, come back in. I like that. Don't let me in. I'm not going to hurt you. There you go. Perfect lyrics for what we're about to talk about. Open Mountain, hopefully set in a nice tone, a nice mellow, therapeutic tone with the heavy topic that we're going on right now. We're talking about how do you talk to somebody you love about suicide. Earlier we talked a lot about myths and statistics about suicide, which are heavy and hard to think about sometimes. So I'm going to spend the rest of the time talking about how do you interact with somebody who has suicidal thoughts or expresses that to you. And earlier we gave an example about how sometimes, and I don't mean to say often, at times I've seen, especially with adolescents, and I've seen this with adults as well, where they'll identify their suicidal thinking in moments of crisis, right? So there's a conflict at home, and the person identifies feeling suicidal during the conflict, right? And it feels like a threat, right? And it feels like the individual is leveraging, right? That's what even we used, right? And it can be, and so just something that you would even say it's behavior that as a parent you would not find acceptable in a kid. So you're in a situation where the child that uses a technique which isn't acceptable, and that maybe you have to use some sort of discipline for, but at the same time they've told you that they're feeling suicidal, and so it's a terrible thing to navigate, and how do you juggle those two things? And I think a lot of times the parent will respond sort of out of instinct, and sometimes it tends to be more therapeutic than others. I think that if I heard that from my kid, if I've never heard it before and they said that to me, I probably would respond poorly. But we make mistakes as parents, right? And so it doesn't necessarily mean that we have to continue to react poorly. Probably I would want to come back later and try to see if we can do some resolve. Probably in that moment isn't necessarily a time to do like a suicide analysis or to really talk about it. And I would argue that if that kid said that out of crisis, they're probably not in a position where they're able to really talk about it and reflect on that with you either. And so and whatever your instinct as a parent, a lot of times I see, when this crisis happens, a lot of times these kiddos come to the ER and then they come and see me, right? But it's whatever it needs to happen, however dangerous the situation is, it needs to happen there, and definitely reach out for advice to whoever's available to you. But I think what I really want to speak to is kind of around this, how do we talk about suicide with somebody, right? Because our goal is to have them, if you have a kiddo or you have a loved one, whatever, to be able to come to you about their suicidal thinking independently of this, right? Outside of the crisis. And really when a kiddo or somebody is only talking about their suicidality in crisis, it doesn't mean they're not feeling suicidal. It just means that during other times they don't feel empowered to talk about it. That the only times they actually have the energy or have the confidence to talk about it is when there's a conflict going on. Okay, and so how are you able to talk about somebody? So if they've never expressed suicidal thinking to you, we'll kind of start there. But maybe you're wondering, maybe you're concerned, maybe their behavior is different, right? Which is a lot of times what people see. Maybe you're concerned they might have depression, right? We really associate suicide and depression to be closely related. I've seen them exist, independent of each other, but usually if you're looking at suicide, the person also has depression. So maybe you're seeing depressive symptoms, which we talked about in earlier episodes. Maybe you're seeing, maybe they're talking about things that we talked about earlier. Maybe they're talking about how they're always alone and nobody's in their life. Maybe they feel like I'm a burden to everyone. Nobody cares about me. Everyone's life would be better if I wasn't around. If they're making those kind of statements. And sometimes they'll go further because we separate suicidal statements as active suicidal statements and passive suicidal statements. So if they're starting to say passive suicidal statements, and passive suicidal statements would be something like, everyone would be better off if I were dead. Or it's, I should have been, sometimes older people will say, I should have been dead by now. I've lived past my time. They're not saying that I want to kill myself, but they're sort of reflecting that they would rather be dead, or I'd rather not be here anymore. These are sort of passive suicidal statements. So if you're hearing things or you're seeing anything, the best way to approach this is to very matter-of-factly try to, with a calm tone, with not necessarily a lot of eye contact, but with a lot of open body mechanics, where your frame and your shoulders and your chest are facing them, your face is facing them, you're sitting at their level or even lower, right, not above them, and you directly ask, have you been having thoughts about killing yourself? And you have to use that language. You have to say kill yourself. Or you have to say suicide. If suicide is a word in their vocabulary, you can use suicide. If you're not sure if they know what suicide is, you have to say, have you been having any thoughts to kill yourself? If you say, have you been having any thoughts to hurt yourself, for a lot of people that's a different thing. A lot of times when people cut themselves or hurt themselves, their intention is not to die. So that's the first thing to do, is to say it. But then here's the fear itself, and I've talked to a lot of my nursing students about it. They're afraid of asking that because what if the person says yes, right? What if the person says, actually, I have been?
And we talked about that a little bit on, I don't know if it was last show or the previous one, but we touched on that where I think that there's a lot of that, right?
Definitely. And I think that is the biggest fear. I don't want to ask because what if they say yes? Or what if they get mad at me? Or what if I give them the idea? So just to sort of squash those, you're not going to give them the idea, right?
Yeah, and by the way, I think a lot of people, and you and I would probably know a lot of people that fall into this category, are thinking that or they don't want the person to say yes, or they don't want to approach that because they feel massively under-equipped to deal with it and massively overwhelmed by it. Now, I'm not saying that helps the person. I'm not trying to make excuses all around. I just think that's the reasoning for a lot of people.
Yeah, absolutely. And so we'll address that one more. Other than I just want to say that that is a myth that if you ask somebody that if they're going to commit suicide, that it's going to give them the idea.
That's really good to know, and more people need to hear that.
Definitely.
Like, there's probably not enough times they can hear that.
Yeah, definitely. It's don't not ask for that reason. Right. As far as them being mad, there might be defensiveness there. That might happen, or they might get mad. But it's definitely worth asking them. Okay. So how do you deal with that? They say yes. Now what do you do? Right. How do you handle this yes? You're not a nurse practitioner in a healthcare setting who has lots of options. Maybe you're a parent by themselves. Maybe you have limited resources. And so so suicidality itself is a mental health issue, is a mental health diagnosis for sure. And so initiating some sort of mental health treatment would be really important, but that's not going to happen in the moment. And sometimes people feel like they need to go to the ER in the moment, and that's really, your decision and your instincts. If you feel like the person's not going to be safe, then sure, take them to the ER. A lot of times that could be a hard experience to go to the ER, especially when you're feeling suicide, because you sit in the ER often for hours, and so it's really important to weigh that. But if the person can't be safe, then that's definitely the route to go. And you can always call. There's numbers to call, and I'll have those available so people know them. But there's numbers to call, and Spokane is first line for help, where you can always get professional help in the moment. But speaking from interpersonally, so if they say yes, I would affirm that. Maybe even you just say, thank you for telling me. Right? I know that's hard, and I really appreciate what you said to me. I can't imagine what you're going through. And I really appreciate you telling me that. If you have that perspective, right, I think doing your best not to be, blown away and not to be reactive, and it can be really hard, especially if you're a parent, to not be reactive and not to become really upset or angry or whatever. Those are all appropriate things to be when you're a parent or a loved one, but doing your best to keep that calmness there and just allow them to talk about it. And with their details, it'll probably help guide your decision.
Just want to throw something out.
Definitely.
And actually would love to even just hear you. Anytime I guess I'm throwing something out, I'd love to hear you speak on it in terms of, just your opinion. Because some of this is, for me, again, counseling people could be, trial, so to speak.
Definitely.
But, I just love the way you were kind of advising people to kind of work through that. And I think to be cognizant, especially if you're a parent or you're a figure of authority that has an intimate place in this person's life, to understand that as difficult as it is for you to try to navigate the question,
definitely,
it could be very difficult for them to answer that. It may not come out as a simple yes. It might be yes, but it might be yelled. It might be, there's a bunch of different ways it can come out, which the darn devil is just trying to use to exacerbate the situation so that relationship doesn't happen. But to just, I guess, stay humble about the fact that this person's willing to go there with you at all, it's a good sign.
Definitely. And if they do become angry, I want to encourage this. Really breaking down what suicidal thinking is when you're thinking about, okay, the suicidal thinking comes from a place of loneliness, and it comes from a place of feeling like they're a burden. So the action of you engaging in selfless conversation, which it is very selfless to ask this question, and for you to be identifying and trying to help them, right, combats both those ideas, right? And so if you're worried that the anger or the defensiveness that they experience, right, whatever that reaction might be, knowing that by you appealing to both those things, you're reducing the risk for harm, not increasing the risk for harm.
That's good to know. I mean, those are the things we can kind of put in our tool belt to feel more confident and safe when we engage.
Even if they storm up the stairs and slam the door, you know that you've probably helped. You've helped in some way. Something from them. So, but here in the opposite spectrum, in the very opposite spectrum, where we're talking about somebody who's chronically identifying suicidal thinking, who's maybe chronically identifying suicidal thinking in crisis. So they're using this as a threat. They're using it as leverage, even if it's very real, okay? What I've seen a lot of times is the opposite will happen, where every conversation has to be about it. Does that make sense? Where we can't sit down at dinner table and I think this comes with that obligation from whoever the support person is, because the support person sees a lot of problems and they want to help and they feel powerless, and so they're constantly bringing up, this has the opposite problem, because this will feed these beliefs. Because if everyone's constantly concerned about your health and wellness, that idea that you're a burden to them is going to worsen. Does that make sense?
Yeah, absolutely. Absolutely.
And I've encouraged kiddos to set these boundaries with their parents sometimes, because the parents are well-meaning, and I've talked to the parents too, right? It's okay for you to tell your whomever, your parent, your brother, your sister, whomever, it's okay for you to say, can we just, for this 5 minutes we're hanging out, not talk about me right now, right? Can we, for this handful of times, talk about the weather, right? Talk about music. Can we be together in some way where there's no stakes, right? And that's what I see a lot. I see these high-stakes relationships. How do we take the stakes out of the relationship? Because that does a lot of things for you, right? If you're having the situation where, like I said, you're often finding yourself talking to your loved one about it, increasing the amount of time you interact with them where you don't talk about that stuff, right? Where you're just spending time with them without stakes. Maybe you bring it up, but maybe you schedule times to bring it up. I say, Jonathan, I want to talk some time. Jonathan's a random name. I just know one named Jonathan I'm treating. Jonathan, I want to spend some time talking to you about what's been going on. Is next Wednesday at 12, can I take you out to coffee, or can I buy you some pizza and we'll talk about it? But we're not going to talk about it until then, right? Scheduling that out might give them an opportunity to cope ahead from that, to really process what they want to say, but it also tells them we're not going to have to talk about this until then, right? Of course, if a crisis happens or something happens, you can make your own, but I think what this does is it allows for these low stakes interactions where the person can pursue relationship more, right? Because the fact that all the interactions have to be about it makes them isolate even more. Kind of talking a little bit more about with adolescents. So let's say it's and this will apply for both situations. Either you've just identified that maybe somebody is a risk for suicide because they said yes to your question, yes, I have thoughts to kill myself, or they're chronically bringing it up. This applies for both. Is to increase the amount of time that you try to have somebody around them, right? And if you're talking about if you have a kid, maybe they're adolescent, pre-adolescent, when you tend to see this happen, or I tend to see this as a professional, I don't know if it's when you tend to see it happen, where you try to sort of enter in their world, which can be really challenging, especially if you're very concerned about their world. But trying to spend time with them, again, in a low-stakes environment. And what I see a lot of times is these teenagers who are very isolating are going to their rooms, they're on their computers, they're on their video games, they're chatting, and so trying to enter that can be really hard to do, right? It can be a huge barrier. How do you engage that world? So it can start really simple. It can be,
especially if you haven't, and people should be really paying attention to all this stuff, because it's all kind of important. It seems like it builds off the other, right? Because you're maybe talking about a parent or a loved one who initially is like, man, I don't want to bother them.
Definitely.
You know what I mean?
Yeah.
And so, whereas you're saying, well, there's some times you're going to need to do that.
You're going to need to bother them a little bit. Or I'll hear, I've told them they have to do this with us, right? I've asked them to go shopping with us, right? I told them they won't go on vacation with us, right? Where whenever we go on vacation, there's a crisis and we can't go, right? I've done all this. They've tried all these things to get the kid to sort of re-enter into that family world, but you probably have to start even slower than that, and you probably have to go into their world. Which, if you ever had a kid or an adolescent talk to you for a long time about video games, right, it could be a long half hour.
My eyes are glazing over as you're talking about it. But this is real because
real.
Now we're talking about a little bit, I wouldn't say but my stomping grounds, like there's a person younger than me, I'm getting old, but that I care about intimately, and this has happened a couple of times where there's this massive opportunity for them to travel and do something that they've never done before and explore their faith. And it's like this amazing, powerful stuff that they can't stop talking about for months.
Right.
And then literally, as it really starts to approach, you can see them starting to freak out and coming up with every excuse in the book to not actually do this thing.
Yeah.
It's pretty trippy.
It's and so you can see, like, even if they're excited about it, and then they're not in a place.
Fear starts to really get them.
Yeah, it does. It can be very dangerous. So, and so what I would even recommend is starting very slow, and maybe it's going into their room and sitting on their bed and just sitting there awkwardly for 5 minutes. But this is what it tells the person. This is what it tells the person. A, you didn't ask them to do anything, right? You didn't get mad at them because they weren't cleaning their room, which you might have already talked to them about that day, okay? You didn't bug them about something else, right? And you didn't ask them about how they're feeling and how their day was. Maybe you asked them a couple questions about what they're doing, their video game, their music they're listening to, or maybe you just sat there quietly for 5 minutes and left, right? But once you've done that, I mean, it's probably going to be a lot of times. 100 times, right? Maybe it's only 10 times. But maybe they answer your question. Maybe they give you 1 or 2 word answers. Hey, what are you listening to? Oh, this person. Okay. Oh, they're pretty cool. Like, yeah, right, Dad, you don't like them, right? But maybe they start telling you about things. Maybe they start telling what they're doing, right? And this doesn't necessarily have to be a lot of time, but I would say it probably has to be consistent.
Yeah, just don't give up.
Don't give up. Because it might take a long time. It might be 100 times. But here's the deal. And so now you have these, and so, whatever point you're at in time, if you're just sitting in their room awkwardly, or now they're finally talking to you, you're having time, or you're spending, your goal is that they'll come to you with it, right? If you ask them, then maybe they'll say yes. But if you've been asking them over and over again, they'll probably say no because they don't want to have the conversation. Your goal is to get that relationship where they'll come to you. And that could be a big goal. And so I think it's important to maybe have smaller goals based on whatever your relationship with this person is. But you want them to come to you with this. Because, I've heard there's a lot of different scenarios here with loved ones. And I know of one where, like a spousal relationship, where the spouse identifies their suicidal thinking regularly, and it causes so much fatigue to the other spouse. So much fatigue to the other spouse. But here's what their issue is. They don't know how to communicate this. They're saying, I'm feeling suicidal. Okay, yes, you are feeling suicidal, right? But what am I going to do about that? How am I going to help you with those suicidal thinking? Let's see if we can be a little bit more precise with our language, right? I'm feeling alone. I'm feeling like nobody likes me. I'm feeling depressed. I haven't slept in 3 days and I feel terrible, right? Let's see if we can become a little more self-aware of this language. And I think that if I was a spouse who experienced this, that's sort of what I would want to find out, right? Because you want to facilitate this relationship where when they come to you about the suicidality, it's like, okay, this is real. This is what we're doing with it, right? But if someone's identifying, to you that they're feeling suicidal every day of the week, right? It's not necessarily new information. I know you're suicidal. You're chronically suicidal. Some people will have that chronic suicidality where it doesn't necessarily go away. A lot of people, it kind of comes and goes. Some people, it doesn't go away, right? And so they're probably just, I'm feeling...
Which is probably really draining.
Extremely draining.
We're talking about don't give up, don't quit.
Yeah.
And with full knowledge that doesn't mean that's an easy...
No, it's not. Yeah, it's not easy. So, and I think what it comes down to is, does your reaction... Does your action or response, does it help sort of fight that aloneness, right, the loneliness, and does it help kind of get rid of the idea that they're a burden in some way, right? And so for some people, feeling like a burden is, it's important for you to come and talk to them about what's going on. That'll help that. And some people, it's not talking to them about it every day, right? And some people, in some people there might even have to be limit setting there, like I really, I think that, I love you and whatever, but I think, not like that. They'll say, I really love you, I really care for you, but I'm getting to a point where I'm not sure how I'm supposed to respond when I'm hearing this from you every day. And so I think that we need to maybe set some limits and some boundaries as to how we're going to communicate this to us, right? Maybe instead of coming to me with this information, maybe you spend a couple minutes identifying what the root emotion is here, and then we can talk about that, right? And so it can be really challenging to navigate it, but really what I want to encourage is a couple of big things here. Don't be afraid to ask, especially if you're worried about it initially. And big, I think, red flags, maybe reasons why somebody's concerned that their loved one is feeling suicidal. Again, number one is that maybe they're, maybe that they've identified it in some capacity, which is really the number one risk factor. Maybe they've identified the hopelessness and the loneliness. Maybe they have co-occurring mental health issues, if they have anorexia, depression, or bipolar disorder, or substance abuse disorder. Those are all risk factors. If you've seen some behavioral change, right? The second biggest one to saying you're feeling suicidal is isolation. Maybe you're seeing some recent isolation. An adolescent young one with some of those other symptoms. Maybe they're being treated for depression. Maybe they've said it a couple times, and all of a sudden they get really isolative, right? That's a good time to go talk to them. If maybe they get really aggressive and agitated sort of out of the blue here, maybe that's a really good time, right? If their appetite changes, that can be a nice subtle one, right? They've lost weight, right? They've stopped sleeping. They haven't slept in 2 days. Usually they sleep fine. Or they have a sudden onset of nightmares, okay? Those are sort of the big, well-established risk factors. If you're seeing something like that, again, not in isolation, right? Not one nightmare doesn't mean that, but when you're seeing kind of a pattern, and especially if you're a parent trusting your gut here, then go ahead and I would say ask the question, right? If they say no, right, then you say, thank you for answering that. I know it's a hard question, and maybe you have reason to believe that they're not being honest. Sometimes people won't be honest, but you kind of have to follow through that path. So those are some signs that maybe why you would ask. Make sure you do ask directly. Make sure you ask, and try to make it a calm, non-reactive voice. A lot of times I use a technique called minimalizing, right? And I'll ask people some of the heaviest stuff you can think of. I mean, suicide is some of the heaviest stuff I can think of, but I'll ask it in a way that almost normalizes it, right? Are you having any thoughts to kill yourself? I'm using a tone that would maybe think that maybe you are, maybe you're not. Other people are. I'm normalizing it, and that gives permission for people to say yes. Okay. If they do say yes for the first time, like I said, you're probably going to want to initiate mental health treatment if you need it. I would use that time. Look, if they're sitting there talking to you, they're not attempting suicide, and so you're going to let that initial conversation be as long as it needs to be, right? And I think I would use this during a time where you have a lot of time, because you're going to want to tell them you have a lot of time and I want to listen to this, okay? If you do identify it, keep in mind when you look at loneliness, when you look at feeling like a burden, and you look at fearlessness, the only two things that are modifiable are the loneliness and the burdensomeness. The fearlessness isn't necessarily modifiable, so you want to focus on how do I allow them to not, because the loneliness can be perceived. They may not actually be alone, right? How do I make them feel less lonely? How do I enter in their world in a way that is entering in their world and not demanding they come into our world? And how do I make sure that they feel supported, but at the same time don't feel that they're a burden? And I think if you whatever your situation is, by sort of modifying it in a way, you're gonna see them open up. And even if they are in a situation where they're only bringing it up during crisis, you deal with that crisis however you need to deal with it, but continue these other methods, because what the goal is that they're going to talk to you about it outside of the crisis. They're going to talk to you about it in a time where they're feeling calm. And so those are my techniques. Thomas Joyner, like I said, is the one who gave me all the details as far as what suicide is and the myths are. But a lot of these techniques are ways that I've found my patients to be successful. So these are things that I've seen people do necessarily. There isn't really a technique there. So I want to encourage people, if you have any questions about this, email me, nick@goodwinhealthcafe.com. I would love to get some questions, and I can definitely address them on the air. I'm going to have my website is coming out. It's still getting updated, but I'll tell you when it comes out, goodwinhealthcafe.com. I will have an answering question section on there. Next time that we talk, I'm not sure if it'll be next week. It might be after the holidays. I'm going to talk about ways to prevent suicidality. How do you prevent this? If there's someone's at risk, what are some things that you can do to prevent suicidal thinking or suicidal behavior on a pharmacological perspective, right? As what medications might be offered. On a non-pharmacological, integrative way, what sort of supplements, diets, stuff like that, what can we do, as well as some behavioral techniques in order to help prevent them. And either that's before maybe the person has risk factors of parents or siblings that have been suicidal, or that you've seen sort of these soft signs, or that they are, maybe in between suicidal. Because like I said, sometimes people will feel suicidal and then it'll kind of go away, and then it'll come back, and then it'll kind of go away. So when someone felt suicidal, had sort of maybe a suicidal crisis, but now they're not feeling suicidal, what are some things you can do at this point in time to try to prevent the next suicidal episode? I know this topic's been super heavy. Like I said, reach out to me if you have any thoughts or questions. This is something that I work with a lot of people who are suicidal, and so I'm very passionate about. And come check in 12:30 a.m. KSBN at 6:05 p.m. We will announce when the next episode is going to be aired, and then I will have these episodes backlogged for you guys. So you guys have a wonderful Christmas, and I will see you all next time. This is Nick Goodwin signing out.